Hi, my name is Mani Alikani. I am Dean and Professor at CTOR Academy, and I'd like to welcome you to another session of CTOR channel. As part of the Back to Clinic series, I'd like to present a very interesting case of a skeletal deformity caused by mouth breathing habit. Nasal obstruction can be caused by many factors. The most usual one are allergy, hypertrophic tonsils, adenoids, nasal septal deviation, or hypertrophic turbinate, and many similar causes. Doesn't matter what caused the nasal obstruction, the outcome is the same. The patients need to breathe from the mouth, therefore they keep their mouth open. If it is chronic, it will be associated with some skeletal changes. Mandibular plane angle will increase, the lower facial height increase, and also if you keep your mouth open for long hours, due to the tense buccinator muscles, the upper jaw will be constricted. That will be associated with crowding in both upper and lower jaw. If you pay attention to these patients, majority of the mouth breather patients have the similar vertical problems. However, sagittally they can have both skeletal class 2 or class 3 patterns. In the patients that have class 2 skeletal patterns, having a mouth breathing habit push the mandibles more backward because they adopt a position for tongue that is backward and downward, and that increases the class 2 skeletal patterns. These patients most of the time have extrusion of anterior teeth and gummy smile. On the other hand, in the patients that have skeletal class 3 patterns, similar to the case that we are discussing today, because their tongue is forward and downward, most of the time they have open bite in addition to all the problems that they have. The skeletal class 3 is actually does not look that bad because mandible is slightly rotated backward. These skeletal deformities need to be addressed. Today, I'm presenting a young teenager, male, around 15 years old, that due to presence of a hypertrophic tonsil and also nasal septal deviation, developed mouth breathing habit for a long time. That was associated with severe skeletal problems, including increase in lower facial height, high mandibular plane angle, and the most severe one, open bite. Let's look at the case together. Clinically, the patient demonstrated class 3 molar and canine, severe crowding upper and lower, open bite, severe, ankyloglossia. In addition, the patient's speech was affected, and that can be expected because the patient had the open bite. When we're looking at the pan, it demonstrates crowding, and the third molar is not erupting in the proper angulation. Cephalometric analysis demonstrated a skeletal class 3 and increased mandibular plane angle. How we can treat these patients? Orthognathic surgery is a classic approach for this patient. But what happens if the patients decided that they do not want to have surgery? Sometimes we can camouflage the result of the treatment by extracting the teeth. In this case, the patient parents did not agree with extracting any teeth. To address the problem of this patient, we have a series of objectives to achieve. To address the transverse problem, we decided to use expander. To make sure the vertical height is under control, we used posterior bite plate. To address the extrusion and proclination of upper anterior teeth because the patient had open bite, we decided to adopt a two-couple system and anterior V-band. To address the posterior height of the lower posterior teeth, we decided to apply one-couple system. Most of the time in adult we can use TAD. Unfortunately, due to the bone density, teenagers and children is better to use one-couple system. Let's see what was the outcome of treatment. Clinical observation demonstrated that patient established a class 1 molar and canine relationship. Overbite and overjet has been re-established. At this moment, patient was referred for a myofunctional therapy to make sure that the patient is starting to establish a proper tongue position, and also a speech therapy to improve his speech abilities. At the same time, if we look at the pan, we demonstrate that all the roots are parallel. The third molar has been extracted due to the possibility of damaging the second molar. This was recommended by his dentist. The CEF demonstrated proper skeletal correction in both sagittal and vertical direction. Patients that have mouth opening habits, most of the time they do not just stop and go back to the nasal breathing even though a skeletal problem has been corrected. They keep that habit for a while, and therefore myofunctional therapy is very important in this patient. However, at the same time, we should design a retainer that, especially at the time of the sleep when they are unconscious and they try to keep their mouth open, we control the height of the posterior teeth. This is very important if you want to have a long-term stability for these patients. I hope you enjoyed this session of CTOR channel. If you have not subscribed to our channel, please go ahead and subscribe. And please don't forget to press the like button.